Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we take a look at recent medical news and headlines. Orthopedic and musculoskeletal medicine is ever evolving, and we're here to review the latest trends for you and help you understand what it means for your health. I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. Steroid injections have been around forever, and they are a staple in the treatment of arthritis, bursitis, and tendonitis. Steroids, of course, have risk, and therefore we need to use them judiciously. But when you ask 5 different doctors, you will get 5 different answers as to how much steroid to use or how frequently to use it for these injections. When I heard last year that a group consensus would be coming out, I was so excited because I'm kind of dorky, but so excited. These recommendations are coming out as a 4-part series. The first 2 are available, and they relate to peripheral joints. So think knees, hips, shoulders, and nerve blocks. We're going to cover these first 2 reviews today. Right off the bat, these guidelines are far superior to most in that it's a multi-society review. We want to see multiple groups formulating recommendations that are going to impact not just pain physicians and orthopedists, but also primary care, rheumatology, and others. Societies involved included the American Academy of Pain Medicine, the American Society of Interventional Pain Physicians, the North American Spine Society, the International Pain and Spine Intervention Society, the American College of Rheumatology, the American Academy of Orthopedic Surgeons, and the American Academy of Physical Medicine and Rehabilitation. The first review is about peripheral joint injections like the hand, the shoulder, the knee, and the hip. They begin by citing evidence that supports the use of steroid injections to improve pain and function in joints affected by arthritis. They looked at different steroid preparations and found no sufficient evidence to recommend one steroid over another. Much of what steroid is used is regional or based on how the provider was trained. They also could not say that the long-acting steroid preparations that are out there worked any better, but they did note that they might not result in the blood sugar spikes seen in some people with conventional steroids. Now, you would think that there would be a consensus on how much steroid to use in a joint, but actually there's a lot of variability. A few studies looked at dosing predominantly in the shoulder, and these studies showed that 20 milligrams of triamcinolone is sufficient for the joint. So this would probably be a good time to explain that steroids are not the same milligram for milligram. Your provider does an equivalency calculation if they want to use a different preparation. So for trigger finger, 20 milligrams equivalent of triamcinolone was recommended. And beyond that, most of the results were from surveys of what providers use, and that was typically more like 40 milligrams for joints like the hip or the knee. They noted that 40 milligrams is as good as 80 in the knee, so a higher dose doesn't work better or longer. There's a lot of variability in what providers use for small joints of the hands. At least one time per day, someone will tell me that they have heard steroids are bad for them and question if it's okay to have a steroid injection. All right. So we're going to go through some of the issues and risks that the authors noted. Anytime a doctor puts a needle in your skin, there is a risk of bleeding. So what about bleeding into a joint? Hemarthrosis or bleeding into a joint can be a major problem. Good news is that studies suggest that it's extremely rare, even on patients who've been taking anticoagulants like warfarin. So we're talking like 0.2% incidence in one study and 0 in another. And the pain societies do not recommend routinely holding blood thinners for joint injections without some extenuating circumstances because the risk of an embolic event off of the anticoagulant, so like a stroke or a heart attack, is higher than the bleeding risk. So good news there. Another area of concern would be cartilage health. Potential detrimental effects of steroids include negative effects on cartilage proteins, chondrocyte availability, and gross cartilage morphology. Animal studies are inconsistent and conflicting. One study looking at cartilage thickness via MRI showed cartilage loss with frequent steroid injections into the knee. Well, that's concerning. Tendon rupture after injection can occur, although that's pretty rare. This might be related to repeated injections, so caution would need to be taken when considering frequent or repeated tendon sheath injections. When it comes to joint space narrowing or progression of arthritis, a Cochrane review showed no relation to joint injection and joint space narrowing. 2 other studies showed that there was more joint space loss in those who'd had steroid injections than controls. Additionally, a rarer finding of osteonecrosis may occur, and that may be accelerated in patients after steroid injections. Osteonecrosis is where some of the bone tissue actually dies because of lack of blood flow. And although this often happens without a risk factor, heavy alcohol use and chronic steroid use definitely increase the risk. And we will often see patients with avascular necrosis of the hip who may receive a steroid injection to mitigate their pain before a hip replacement. And it's important to just tell these patients that the injection may accelerate the problem, and often they still will elect for the injection anyway because they need some temporary relief until they're ready for can have surgery. Now, patients often ask about osteoporosis. We've talked about osteoporosis in another episode, and we know we want to mitigate it, and steroid use is a risk factor for osteoporosis. So what do we do with this? One author found reduced bone mineral density in patients who received more than 200 milligram equivalents of steroid in a year. Another study found no increase in fracture risk in patients with a less than 200 milligram equivalent per year dose. So with that in mind, the authors agreed with prior work, which recommended less than 200 milligrams per year and less than 400 milligrams per 3 years in postmenopausal women. They cautioned, however, that the provider really has to balance pain and function with the potential for reduced bone mineral density. So think of it this way. If you're 80 and you're a poor surgical candidate and you're in a lot of pain and these injections help, it probably makes sense after discussion with your doctor to continue the steroid injections at the lowest effective dose. This isn't a set in stone number, but we should be cognizant of what other effects the steroids are having. The authors cautioned to use the lowest dose, not to do these injections as a series, but to see the patient's response before deciding to do an additional injection. I tell patients all the time, these injections are not prophylactic. Don't get them just because it's been 3 months since your last one. Wait until your symptoms are recurring before getting another steroid injection. Now, adrenal suppression may also occur. Usually this is not clinically significant. After 2 to 3 weeks, this should be resolved. So waiting 2 to 3 weeks between injections is recommended if possible, if tolerable. Again, some of this wait time will be dependent on the dose that's used. Now, what about diabetes? I hear all the time from patients that their blood sugars have been high for months after steroid injection. The data doesn't really support that happening. Blood sugar does rise in patients with and without diabetes after injections, typically within the first 1 to 3 days, and may last up to a week. Most resolve within 24 hours. Poorly controlled diabetes or significantly elevated blood sugars, most of us use the cutoff of 200 to 250 where we wouldn't give an injection. That should give you some pause. Infection is a rare, but anytime a doctor injects you, there's risk. In patients who are planning joint replacement, though, there is an increased risk of infection with steroids within 3 months prior to surgery. So most orthopedists will not recommend that you have a joint replaced until it's been 3 months. So consider that in your timing. All right, so what about peripheral nerve blocks or trigger point injections? What do we do with steroid for these? Now, this second article in this series recommends steroid only for greater occipital nerve block, that's back here, back of the neck or back of the skull, for cluster headache, which is a fortunately rare and specific type of disabling headache. Ilioinguinal, iliohypogastric, genitofemoral nerve blocks, this is in the groin for post-hernia pain, and injections of the Morton's neuroma pain, and that's in the foot. They specifically do not recommend steroids be used in sympathetic nerve blocks, in those greater occipital nerve blocks, so back of the skull blocks, for medication overuse headache or migraine, injections in the carpal tunnel, or for trigger point injections. This really helps, particularly with the debate regarding trigger point injections. So trigger points are these taut muscle bands that hurt. And when you push on them, you can actually feel the pain radiate out. And I inject them all the time to provide some temporary relief and facilitate therapy. This review shows the same benefit with anesthetic only, so like lidocaine only, which is great because we can decrease a person's total steroid dose. So in summary, we have been using steroid injections forever, and they're not going anywhere. And we know not just from the data, but from our clinical experience, they help a lot of people. But like everything, moderation is key. And we want to use the least amount of medicine that we need to get the desired effect. Risks exist. And most importantly, if you are diabetic or you have osteoporosis, you need to be judicious in their use. For me, the biggest change I see with these reports is that I've been able to reduce the dosage I use in my shoulders. And for most cases, steroids have been removed from peripheral nerve blocks. Now, let your doctor know if you're getting injections from other providers as well. It's important that we know so that we can modify the dose that you receive if needed. Now, I am really looking forward to parts 3 and 4, which are going to tackle spinal injections, and we can update this episode with that information then. Thank you so much for listening today. I hope you heard something you can use. Please subscribe to us and share it with a friend. We're constantly adding new episodes, and you don't want to miss out. Wishing you good health. See you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.